Okay, everybody, here we go at Chapter 9. These are medications that affect coagulation. So we'll jump into that here. Okay, first a little introduction on some terminology that we need to go through. So blood naturally contains coagulants which promote clotting and anticoagulants which inhibit clotting, and these are dominant in the blood. They keep the blood in liquid form. Intraoperatively, it might be necessary to assist the coagulation process in damaged blood vessels. We do that with bovie, suture, ties, clips, etc. And it might be also time for some topical hemostats. These are coagulants used on areas of capillary bleeding. We also have systemic anticoagulants. These are given intraoperatively when clot formation is undesirable. So for example, heparin may be given IV by the anesthesia care provider or topically applied from the sterile back table during peripheral and cardiovascular cases. Some are given in the medical setting to prevent DVT, which is deep vein thrombosis, or PE, or pulmonary embolisms. These are common post-op problems that we've talked about before. And then we have thrombolytics. These are agents that are used to speed up the clot breakdown. And they're used when a clot is formed in an intact vessel. All right, so talking about clot formation, the body's natural coagulation prevents blood loss to small vessels. But when damage is done to large vessels, that's when surgical intervention is required. Okay, damage to a small vessel causes a spasm and the tissue damage that starts a series of reactions. And this is our clot formation. The reactions cause the production of fibrin, which is a protein that sticks to the vessel, forming a platelet plug. And then clot formation happens in 3 main stages. So in stage 1, thromboplastin, also known as prothrombin activator, is formed. There are 2 mechanisms that are involved for thromboplastin formation, the extrinsic and intrinsic pathway, and those meet at the common pathway. Okay, the extrinsic pathway is initiated by factors outside of the blood, and it produces a clot within seconds. The intrinsic pathway is initiated by substances in the blood. It's a little bit more complex. It takes several minutes, and there are a total of 13 clotting factors that we're not going to go through one by one, but there is a table on page 118. That's table 9.1 that does have a complete list. Okay, for stage 2, thromboplastin converts prothrombin, which is factor 2, into thrombin. And in stage 3, thrombin converts fibrinogen, which is factor 1, into fibrin, which forms a net that traps blood cells and forms a clot. Okay, so stage 3 is when that fibrin is formed. So here's a good example, a little bit of an illustration. Here we can see our damaged blood vessel wall and our red blood cells and our platelets floating around in here. Once those platelets are activated and fibrin is formed, that's what all of these little strings are, then our clot starts to form. That's where our clumping takes place. And over here is a microscopic picture of a fibrin clump. So all of these white kind of stringy spiderweb looking stuff, that is our fibrin around our red blood cells. All right, so now we're going to talk a little bit about coagulants. These promote, accelerate, or make possible blood coagulation. There are 2 major categories. Hemostatics are topical agents, generally used most exclusively in the surgery setting, and systemic coagulants that are generally used in the medical setting. Hemostatics in surgery are applied topically in the form of films, powders, sponges, or solutions. And each is applied or supplied in sterile packaging that can be opened up onto the back table. And there is a box 9.1, again on page 118, that lists these in total. So we're going to start off with absorbable gelatin. These are animal in origin, made from purified porcine skin. gelatin. That's from the USP. And if you remember, porcine refers to hogs and pigs. It's absorbed completely, usually in 4 to 6 weeks. It can be used dry or moistened with saline. Should not be used in areas of infection, nor should it be placed intravascularly. So it should not be placed within the vessel itself. And some examples of this are gel film. When dry, it has the consistency of cellophane. Once it's moistened, it becomes pliable, and it's approved for use in neurothoracic and ophthalmic surgery. So once that is moistened, we can bend it, shape it, and cut it to whatever size we may need. Next, we have gel foam powder. That can be mixed with saline and made into a paste. The powder form promotes granulation, so we may use the powder form alone when we're working on areas excuse me, with skin ulcerations to promote that granulation. All right, going on with the gelatins, next we have gel foam sponges. These are commonly used in ortho, general, otolaryngology, neuro, and dental procedures. So this is a very wide spectrum, very commonly used gel foam sponge. We use it a lot. Then we have Gel Foam Plus. This comes in a kit containing human thrombin, sterile saline, and a 10mm syringe with a needle. The gel foam sponge contained in the kit is moistened with the thrombin solution and applied to the bleeding surface. We also have the Gelita Spun. This induces hemostasis through its porous surface. It absorbs about 40 times its weight in blood and fluids. It does form a clot and induces platelet aggregation, which is just a fancy word for clumping. And it is absorbed in less than 4 weeks. Okay, next we have the Flow Seal and Surgiflow. These are our flowable form. Conforms to uneven surfaces. The kit contains gelatin granules, human thrombin, saline, and the delivery system. And once mixed, it should be used within 4 hours. This is another common combo that we use a lot, Flow Seal and Surgiflow. They are very, very commonly used in surgery. Okay, so here are some examples over here on the left. These are examples of the gel foam sponges. So as you can see, these are just 2 sizes. They come in a lot of different sizes and widths, but it is very pliable and we can cut it down to whatever size we need. In the middle is the gelatin spun, which is just another variant of this, the next generation. And over here is the setup for the Surgiflow or Flow Seal. They both look very similar. So here we have the thrombin granules, thrombin granules are here. This is our solution that we're going to mix up. Usually we will draw it up in this syringe, the saline, and reconstitute it. We'll pour it out into this cup. It gets drawn into this syringe. And then this syringe, if you can see on the tip here, will screw into this one, and we will push these plungers back and forth to mix them all together. And then these are our delivery spouts. Okay, moving on to the absorbable collagen sponges. These are made from purified bovine collagen, which we remember bovine stands for cattle. When applied, it promotes platelet aggregation or clumping, may reduce the bonding strength of methyl methacrylate, which is the liquid portion of bone cement. So it is contraindicated to be placed on bone before cementing a prosthesis in. And a couple examples of this are Helistat and Hilitine. Okay, the microfibrillar collagen hemostats, or MCHs. Avitine is a common one that we use quite often. It attracts platelets to the substance and triggers a fibrin clot formation that way. This is purified corium bovine collagen. It should be applied with dry instruments because once it is comes into any contact with a moist surface, it turns to glue, so it will adhere to any moist surface. Contact with non-bleeding surfaces should be avoided, and any excess should be rinsed away with irrigation within a few minutes of application. It is available as a powder, in preloaded syringes, and in sheets and sponge form. Okay, then we have Instat MCH, which is derived from bovine deep flexor tendon. That is a pure collagen. It allows the surgeon to grasp only the amount needed with some forceps and apply it to the irregularly shaped surfaces that we might be working on. The onset of action is 2 to 4 minutes, and it is absorbable, but removal is recommended. And finally, we have Arista. This is plant-based absorbable powder. It's derived from plant starch. This contains no thrombin, and it is absorbed within 24 to 48 hours. It comes as a fine white powder in its own container, and it is contraindicated for neuro and ophthalmic surgeries. All right, moving on to oxidized cellulose. Hemostatic action for this is not clearly understood. When it is applied to bleeding surfaces, it becomes kind of a gelatinous kind of mass that serves as a nucleus for clotting. Oxidized regenerate cellulose, or ORC, is the newest version. This comes in knitted gauze strips or in fiber form. It is best applied when dry. It's commonly used in neuro and otolaryngology. And the most common form that we're using now is Surgicel. Surgicel is also bacteriostatic. Right, we're going to talk a little bit about thrombins. These were initially derived from bovine origins, so from cattle. Some patients developed antibodies, so human-derived and recombinant human-derived were developed in 2007 and 2008. Those were brought about. It may come prepared in a spray bottle, kit, or in a powder form that must be reconstituted. It should be used immediately after preparation. Okay, thrombin should always be used immediately once it's prepared. It may be applied topically as a solution, powder, or in combination with a gelatin sponge. So if you remember, we've talked before about keeping thrombin in a petri dish on our back table for our gel foam to soak in. That is where this would come into play. This is measured in units, and it comes in strengths depending on the type that we're using. A topical human thrombin comes frozen. It needs to be thawed before application. Vitagel is one form of this. It's thrombin combined with microfibrillar collagen, mixed with the patient's own plasma that is drawn at the beginning of the procedure and spun out. It is not to be used in neuro or ophthalmic surgery. Right, then we have Tisiel and Evasil. Thrombins are combined with other agents to form fibrin sealants in these. Tisiel comes in a freeze-dried kit that has to be reconstituted, or it comes in a frozen pre-filled syringe that needs to be thawed before use. And Evasil is supplied in a kit of 2 syringes, one containing human fibrinogen and the other containing human thrombin. Those both are also thawed before use, and then they come with a sterile delivery system that is delivered to the back table. Okay, Tisiel and Evasil are our other 2 very common thrombins that we use. And then we have just a few miscellaneous agents that are used as hemostatics, the first one being bone wax. This is a topical hemostatic. It's made from beeswax. It is used primarily in ortho and neuro cases because we're usually, as it states in the name, putting it on bone. It acts more as a barrier than a hemostatic, but it does plug up some of that porous bone tissue that sometimes gets exposed. The way that we use this is we will just pull off a small piece, usually a corner at a time, and we'll roll it between our fingers into little balls, and then we deliver it to the surgeon on either the tip of a freer or maybe a key elevator or a peanut sponge, something like that. And they'll use that to get it down into the bone that we're using. Okay, moving on to some of our chemical hemostatics. First, we have tannic acid. This is a powder made from an astringent plant. It is applied topically to mucous membranes to stop capillary bleeding. It's often used in combination with neosynephrine, and most commonly we're going to use that combo post-tonsillectomy. So once we have those tonsils out, we will soak a tonsil sponge in this solution and put it to the back of the throat to help with that capillary bleeding in that tonsil bed. Okay, next we have silver nitrate. This is another one that we use quite often in multiple different types of cases. This is mixed with potassium nitrate, and then they're molded onto applicator sticks. They can also remove granulation tissue and warts, so we do use them for that as well. The tips are moistened with sterile water and then applied to the area for treatment. A good note though is that these are caustics, so they should not be used around the eyes. Okay, and another chemical hemostatic that we will use quite often is Moncel solution. This is a deep brown mixture of ferrous sulfate and sulfuric acid along with nitric acid diluted with water, or it's available as a paste as well. It is usually used in gynae and applied to the bleeding surface of the cervix following a cold cone biopsy. And a note about Moncel solution is that you can see here it is deep brown in mixture, very similar to the Lugol solution, which is also deep brown in mixture. So we need to be sure if you have both of these items on your table, they are clearly labeled because they do have a very, very similar color and texture. Okay, we'll talk a little bit about systemic coagulants now. These replenish deficiencies in the natural clotting mechanism. If needed, they're usually administered preoperatively or by the anesthesia care provider intraoperatively. They're used to replace calcium and vitamin K or some of the coagulation factors in the blood. Deficiencies may be hereditary, such as hemophilia, or they can be acquired, like a vitamin K deficiency. These systemics can be administered IV, IM, orally, or subcutaneously. And there is a box 9.2 on page 122 that provides a complete list of these as well. And we'll touch just briefly on calcium salts. Calcium is the body's most common mineral, and it is vital to the coagulation. If the calcium levels fall during surgery, the anesthesia care provider may administer some calcium salts IV. An example of this is during a transfusion. The anesthesia care provider will monitor calcium very, very closely. And that is because donating blood sometimes tends to strip that donated blood of the calcium. So our anesthesia care providers are going to keep track of that quite closely when we're administering a transfusion to make sure that they do or do not need to put some calcium salts in through the IV. And then we also need to note that calcium salts are contraindicated in patients with a history of malignant hypothermia. And that is because one aspect of MH is increased calcium release from the muscles. So we do not want to give it to anyone that has a history of MH. All right, vitamin K. Vitamin K is fat soluble and it promotes blood clotting. In a surgical patient with a vitamin K deficiency, it can lead to excessive bleeding. So if needed, it can be administered orally or subcutaneously, but it does take up to 24 hours to produce an acceptable effect. So if a surgery is urgent, it can be given IV, but it takes 6 hours for that acceptable effect, and it poses a high risk for anaphylaxis. So ideally what we would do in this situation is give the patient fresh frozen plasma in lieu of the vitamin K. Right, and blood coagulation factors. So deficiency of any clotting factor is going to obviously disrupt our coagulation abilities. 2 clotting factors are administered IV in the medical setting, and those are 8 and 9. Factor 8, however, is absent in patients with hemophilia A and it'll have to be administered preoperatively. And the same goes for factor 9, that it is administered IV preoperatively in patients with hemophilia B. All right, now we're going to move on to some anticoagulants. So these are drugs that interfere with blood clotting. They do not dissolve clots that are already formed, however. Okay, they're administered in the medical setting to prevent DVT, PE, acute coronary occlusions after an MI or a myocardial infarction or heart attack, and strokes caused by embolus or cerebral blood clot. So that's what it is administered in the medical setting for. It's given to surgical patients prophylactically with a history of arterial stasis or arterial stiffening or plaques, or who may be immobilized for an extended period of time. Remember, if these patients can't get up and move around right away after surgery or as soon as possible, that's when we have a risk of clot formation. So if they are going to be immobilized, we will give them an anticoagulant prophylactically. It may be given intraoperatively in patients that have undergone vessel trauma or manipulation. Okay, so if we're working on somebody's femoral artery, for instance, we're doing a femoral embolectomy, we may give an anticoagulant to make sure that that blood is flowing through and is not going to clot against any kind of trauma that we might have caused when we manipulated that femoral artery. Okay, so some parenteral anticoagulants. Remember, if we're talking about parenteral, it's usually anything that's going to happen intraoperatively because we cannot give them enterally. That is the oral route, and our patients are not able to do that in surgery. So parenteral anticoagulants, we're going to talk about heparin. That's the big one. Okay, heparin sodium is the most common parenteral anticoagulant, and it's used in both the medical and the surgical setting. It's highly negatively charged sugar molecule, and it's derived from porcine intestinal mucosa. So it's from pig mucosas. It acts by inactivating several clotting factors and thrombin. It binds to plasma proteins, which explains some of the varying reactions that we do see in patients regarding heparin. It does not cross the placental barrier, but there are no definitive studies on the effects of use in pregnant women, so this is where that risk versus benefit decision comes in, usually made by the surgeons. Okay, it's measured in units rather than milligrams, and it's available in doses of 10 to 40,000 units per ml. It is available parenterally because it is poorly absorbed through the GI tract. That is why we most commonly give it parenterally. Okay, heparin is available for injection as well in 1 milliliter single dose vials and in some premixed forms. Okay, the onset of action is rapid, usually within 5 minutes, and it does last 2 to 4 hours. It is contraindicated in patients with thrombocytopenia, which means decreased platelets. The primary anticoagulant used intraoperatively, most commonly in peripheral and cardiovascular procedures. So as I said before, this is really our go-to in surgery is heparin. Okay, during, as we talked about a minute ago, a femoral embolectomy, heparin's injected directly into the affected artery through an arterial irrigating catheter, and that is to make sure that our blood is flowing freely through there and we're not going to clot. And during a venous access port insertion, this is another instance where we will use heparin, but we may use it in different strengths. We may use it in 10 units per milliliter and also 100 units per milliliter. And they are used at different times, so that is where our diligent labeling comes in, our accurate labeling, and we're making sure that we are repeating out loud to the surgeon what it is that we are giving them. Okay, moving on to protamine sulfate. Protamine sulfate is the antagonist to heparin. Okay, it's parenteral anticoagulant that binds with heparin and inactivates it. It's highly positively charged protein that's derived from salmon, and it may be used to reverse heparin overdose or to reverse heparin-induced anticoagulation. So this is the antagonist to heparin. We can use it to reverse the effects if need be. And it is usually administered very slowly via IV by our anesthesia care providers. Okay, low molecular weight heparins, LMWH, has a lower affinity for plasma protein binding, resulting in a lot less variability among patients. The common trade names for these are Inahep and Lovenox. These can be prepared and sent home with patients to be administered subcutaneously. A lot of times you may see patients that are on this at home preoperatively, and they'll come in and you can tell because they usually have some bruising around their stomach area, and that lets us know that they're taking these low molecular heparins at home. Enoxaparin is used to prevent post-op DVTs in patients that have undergone abdominal surgeries, hip replacements, or knee replacements. It is contraindicated in patients with a hypersensitivity to heparin or to pork products, and that is because obviously these are porcine derived. Okay, we have factor XA inhibitors. The trade name for this is Arixtra. These are used for post-op and long-term prophylaxis of DVT in patients that have undergone either orthopedic fracture surgeries, total joints, or big abdominal surgeries. It is a synthetic chemical. The trade name for the oral routes of these you may have heard before. They're on TV all the time. That's Xarelto and Eliquis. But there is a caution on this one. Remember a little bit back we talked about Arista, which is a topical hemostatic agent. Then we have Arixtra, which is an anticoagulant. So those are very similar sounding, but they have completely different indications. So we need to just be aware of that similarity between them. Okay, we have the oral anticoagulants. Obviously, these are not going to be used in the surgical setting because they are oral. They have a delayed onset of action. They shouldn't be used in emergent situations. They're used for long-term care of patients with thromboembolic disease, DVTs, PEs. Coumadin is a widely prescribed medication for this indication. So we've talked about Coumadin before. And it works by vitamin K antagonism. So vitamin K is the antagonist to Coumadin. This is metabolized in the liver. It's excreted in the urine. Aspirin is another oral antiplatelet drug that's considered an anticoagulant. And it's advised that if possible, these patients discontinue their oral anticoagulants 1 week prior to surgery. And that is just to avoid any major bleeding mishaps. Sometimes it's not possible, and then it's the surgeon's discretion as to whether or not they continue. Okay, and then finally we have thrombolytics. These are given IV in the medical setting to help dissolve blood clots. So they are in the medical setting, not in the OR. They're used to treat acute myocardial infarctions when coronary artery thrombosis is present. And they may be used in combination with anticoagulant therapy, as clot formation is kind of an ongoing process. But again, this is another one that is used in the medical setting.